want to do an icebreaker? Yeah, let's do an icebreaker actually. That's fun. That's fun. That's all right. Oh yeah, maybe. Okay. Okay. Icebreaker for the day, of course. Your name. Start off with your name, and then what would you bring with you to the desert island?
Yeah, a deserted island.
Oh, a deserted island.
Well, because there's nothing there yet.
Oh, but it could be a desert island though, 'cause then like that might very nice.
It could be a desert. Like there's nothing
Oh,
there.
there's
It
nothing
also
there.
happens to be desert. And because we're usually short on time, one thing.
One thing you take. All right, I'll start us off. Bring my dog.
Your name?
My dog's name?
No, what's your name?
Oh, my name is Thomas, and I would bring my dog with me as a companion. Yes, that is it. Oh wait, we started there last time. We started with you last.
I'm Liza, and I would bring my bed.
Nice, good call.
I'm Jillian, I'd also probably bring my dog.
Nice.
I'm Brooke, and thinking logically, I would probably bring matches, probably, because I'm for fire, which can be used as protection, or if I find some sort of thing I can boil water.
I like to think.
Is it surrounded by water?
It's
Yes, it's
it
an
is.
island. Well,
Yes.
it's an island.
And but the thing about that though, that there's also it also is there. It's desert, right?
Yeah.
So it's deserted and it's desert.
Oh,
So
like sand?
But there's
like
no
sand desert. See, there's no wood.
Yeah, Liza wants to think.
Oh, last year.
I bring a frisbee
I was gonna say.
Oh yeah, that's
Yeah.
smart.
Okay,
I was gonna say-
I thought you were talking like tropical islands.
No.
I'm gonna bring a boat. Just leave the island.
Okay.
That's such a good point. All right, Annika.
Send her away from someone.
Smart. Annika or Annika?
Annika.
Okay.
I like
I
that.
never know.
Okay. Pound mile sponge.
A what?
I can soak up all the water from food.
Oh.
Sprout out the fish.
All right. And leave.
And your name again?
James.
Oh, James, good.
Just in case I couldn't read your name.
Yeah.
I'm Bryce. I'm probably here with my dad.
Nice.
My name is Aiden. I would also bring my dogs.
Nice.
I'm Andrew, and I would probably bring a boat, I guess.
All right.
I'm Caroline, and I would bring Marcella.
Out of all the things you could bring,
Not
Caroline.
even a bed.
Why don't you just bring?
Not even a bed, just the pillow.
She wants to be up there.
Alright, go ahead.
Dolphin.
My name's Dalton, and I would probably bring like a knife so I could sharpen like stone. I don't know. I would like sharpen
Sharpen
stone.
sand.
And then be like attracting fishermen and be like stabbing the fish.
Oh, okay. And there's got to be some rocks in the ocean,
Yeah.
right? Somewhere.
I'm Hickory, and I would bring a friend, so don't count me.
Oh,
I like
that's
that.
good. That's a good answer. Bernardo?
I'm Bernardo, and I am honestly the only
That's
Okay,
fair.
Bernardo.
That's fair.
I'm Maggie, and I'd probably bring either a plane or a helicopter or
Oh.
something. I'm Kiana, and I'd probably bring a lot of water, because
Stay
if
on.
it's a desert, you're going to have
That's true. Good. Look at that. Already thinking about it. Hold on. And Sally?
My name's Sally, and I would probably bring a friend as well. Undecided which one. I think I would have to have a long process deciding
Yeah.
who to come.
An application process. probably.
Yeah, exactly. Interviews. Probably take a first aid class together.
Yeah.
Basically, Post 53.
Yeah.
Yeah, exactly.
Yeah, they definitely would be a member of Post because
Oh,
then I know
yeah.
they could save me if I went down, and I could save them.
Oh, that's smart. We have some guests today. We have Belle. What would you bring on Desert Island, Belle?
That's a hard question. Way to put me on the spot, Thomas.
I know.
Probably like a desert island. Wait.
A deserted island. It's a double.
All right, I would bring what's it called?
Spear.
A spear so that I can kill some fish and eat them.
Nice. Allie?
I would bring matches because I can't light a fire to save my life, and I feel like that would be kind of a necessity.
That's
Yeah,
true.
your face.
Except for the one
Or you could
consideration
just
is that
fry
there's
it on the hot
no
sand.
wood.
oh on the hot sand. I don't. Okay.
So I don't know if there's any logic behind it.
Yeah, but that works.
Start a fire on
Well,
it.
it's
I'm sure you could get a cactus or something where.
And Will?
Alright, yes, as Thomas said, my name's Will. Hi, everyone. I was on a deserted island and it was desert. I think I took a fishing rod.
Nice.
Well said. But I like fishing and I like food. I'll have to.
spear fishing is more
Mrs. Notteraw, would you like to go?
Sure. I guess I would bring a candy.
Oh,
Yeah.
smart.
We're so
Oh, so you don't just like shrivel.
I would not last a second on a deserted island. My pale shoes gone. That's it.
Okay, so with that, you want to stay
You stay on track today.
So we're going to get started with the material. So today we're going to be talking about various things. It's a little blurry for some reason, but class 3 obviously, pages 35 to 41. And then we kind of jump and then go to 50 and 54. So just when you guys can actually probably write that down, just so when you're studying for the quiz.
It'll be a good classroom again.
Yep, we'll put it on Google Classroom. Quizzes, we'll give you quizzes back next time. Or, I mean, we obviously just gave you those back, but we'll give you the ones from today back next time. And if you have any questions, don't be afraid to ask obviously during class or email us when you're studying it. All right, perfect. So we'll start off. So head and spinal injuries. I think we figured out, by the way, the whole like mess up thing. I think
We got it down
to
now.
So, so to start off, we're going to talk about different types of head injuries. So we have scalp wounds, skull fractures, and brain injuries.
All right, so scalp wounds, just like it sounds, it's a wound to the scalp. So the main care is just control bleeding, just like we talked about already. And then just keep the head and shoulders elevated if the spine is also not suspected an injury. So let's say they just cut themselves, it wasn't involved in like a fall or anything, so you know their back and neck are okay. You can keep their shoulders and head elevated. And then of course, seek medical care, anything involving the head really, why not?
Okay, so then moving on to a skull fracture. So we first want to identify the things or how we can recognize if it is a skull fracture. So this is going to be pain at a point of the injury. So if someone, you can see that there's visible injury, they say that it hurts, pretty self-explanatory there. A break or deformity, loss of consciousness, drainage from the ears or nose. What liquid could be coming out of the ears?
Cerebrospinal.
All right, good work. Then heavy scalp bleeding or a penetrating wound. A penetrating wound to the skull, that's not great.
Alright, so care for a skull fracture. So you want to check responsiveness and breathing, which I know Beta demonstrated for us last time. And then you want to apply sterile dressing. Anyone sterile? What does that mean again?
Clean.
Perfect.
And then just apply pressure around the edges of the wound, so you can see how he's not just like pressing on the part of the skull that's injured, just around the wound. So you're not. The brain's like a very sensitive, obviously, piece of your body, so you don't want to apply pressure directly there. And then just stabilize the head and neck and call 911, and we'll learn about stabilizing the head and neck by the end of this class.
So skull fracture, things that we do not want to do, and these also translate to a lot of things that we do on the ambulance, so very important. First off, you don't want to move the head or neck at all, head, neck, or spine, that is. Of course, just like Sally kind of mentioned there, the brain as well as your spinal cord are very, very sensitive, and any injury can cause serious damage and paralyze you. So we want to be super, super careful with that. You don't want to clean the wound, which is kind of counterintuitive, you're probably thinking, but when it comes to skull fractures, you don't want to clean the wound. You do not want to remove the embedded object. We talked a little bit about this when it came to penetrating wounds. They could be stopping the bleeding or holding things in place, so you never want to take it out, because then that means the bleeding could start up, or then the brain could shift, or the skull could shift, and then suddenly, again, you have more injury than you started with. So you just want to leave it in there. Do not stop the blood or clear fluid coming from or draining from the ears. We talked about this last time a little bit. That's kind of a very natural process. And as well, you never want to create a blockage in the ears, because then that could build up and then also go into your head. So you just kind of want to let that flow out. And finally, do not press on the fractured area. We'll talk about this a little bit when we come to splinting as well, but this kind of just makes sure that, again, you're not causing more harm than good by helping this person out.
Alright, so brain injuries, so recognizing brain injuries, this is kind of a little more difficult, not something you see daily or anything like that, so you just want to know, vacant stare, so if someone's staring off, completely like out of it, like, you would notice if someone's just staring and you can't really get their attention well. So slow to answer questions, so that could either be like the next point, unaware of time and place, they could be confused, they could just be, lagging in their speech. Slurred speech is also a big one as well as stumbling over your words or in like physically stumbling. And then loss of responsiveness, of course, would be a big one. And then last three, headache, dizziness, nausea. We ask that on like almost all of our calls, pretty much. You know, does your stomach hurt? Do you feel dizzy, nauseous, anything like that? I think Matt get it.
It's gonna be kind of a dumb question, but would the concussion count as brain injury or is that what it's
Completely. We're gonna go over that. I'm pretty sure it's in this slideshow, but yeah, concussion's a brain injury.
Also, is this also for like impaled objects?
Yes, but that would more be like, I think that would more go into like scalp or skull wounds, you know, just because
Yeah.
that's like an open injury. This is more like something happened inside, or you had a skull fracture. Like, you know what I mean? You have bleeding, and if you saw a vacant stare or they're stumbling or something like that, you could say, oh, it could be more, it could be deeper than this, and it could also be a brain injury.
Okay. Yep, Caroline.
Is there always bleeding for a skull fracture?
Nope. Something for like a concussion, right, would just be internal. Other things, if someone just like hits their head and it's not necessarily a concussion, you could still have some of these symptoms here, but it's not necessarily bleeding. The only time that there would be bleeding is if it kind of comes along with, like Sally just touched on, it comes along with a skull fracture. And you have, you cracked your head open, right, and then they have some of these symptoms, but as well, of course, you have the physical trauma to their head that's causing the bleeding. Does that make sense? Okay, so it's kind of a case by case there. Yeah, Maggie.
Would these like symptoms, if would you feel that they start happening immediately or after time?
I think it depends. It depends also on the severity of it. If you obviously, how many of you guys had a concussion before? Probably a lot, right? Yeah, decent amount.
So many people.
So at least I had a concussion back in like 7th grade, and for me, it wasn't really right away. Obviously, the injury happened right away, but I didn't really feel the effects of the concussion where I was like obviously they always talk about bright lights and things like that. That wasn't until maybe a couple hours after the accident. But again, it depends on the severity. If it's really serious, it could be right away. Something like loss of responsiveness, a lot of times when someone is in a very, let's say, serious car accident, they'll hit their head really hard, lose consciousness or responsiveness right for a number of seconds, and then they'll be back to normal. So depends on the severity, but for the most part, they'll come, I would say, anywhere from immediately when the injury comes to like within 24, 48 hours, something like that. All right. So care for brain injuries, so first we're going to want to be doing is checking responsiveness and breathing. And we talked about this a lot the first class and touched on it a little bit last class as well. So we're going to be using tap and shout to check responsiveness, and then look, listen, feel for breathing. You also remember what that is? Look, listen, feel. Perfect. That was one thing on the first quiz you just got back there. So you also want to be sure to control the bleeding with the sterile dressing to make sure that they're not excessively bleeding. And again, we've already said this once or twice now, but if you want to apply pressure around the edges of the wound if there's a skull fracture, never on the fracture. The way I always thought about it is if your skull is kind of like arched like this, and then you have a fracture, let's say your skull kind of like juts in like that, and now you're putting pressure on that piece, and it's pressing into the brain. That clearly is not a good thing to do, so that's why you want to put pressure on the edges, not in the center. Yeah, Bryce?
Don't you always assume that it's a skull fracture?
You repeat that, sorry?
Don't you always assume that it's a skull fracture no matter like what's happening?
You,
If it's a head injury, you assume it's a skull fracture.
again, I'm thinking EMT knowledge. I'm not sure what you think.
First aid, I would say, always err on the side of caution. So yeah, you're always gonna assume, you know what I mean, like prepare for it to be worse. I would say that's tough. I would say EMT wise, no. First aid wise, treated skull fracture, brain injury, err on the side of caution. So if you think something could be wrong with their skull, stabilize their head and neck. Why not?
And also, skull fracture should be pretty obvious. If they actually fractured their skull, the person will be complaining of it, or you would see that as well. So I have a question down here, not anymore. Oh yeah.
Because the skull fracture is always bleeding.
Sorry, repeat that as well.
It's like for bleeding of the head, is it always going to be a skull fracture?
I mean, there are a lot of injuries that you could have, right? You can just have a little laceration on your head. Sometimes you have internal bleeding or subdural bleeding, which is like between the brain and the skull. But for the most part, I mean, the bleeding levels vary. I mean, if anybody's ever cracked their head open, I haven't done that, but sometimes then there'll be lots of bleeding. Other times there'll be more internal injuries where there won't be any bleeding at all, kind of like we talked about with concussions and things like that.
And skull fractures, like you can also have, like you can see a deformity and maybe it's not bleeding, maybe nothing penetrates the skin. That's another option.
Yeah.
And then if it's bleeding, do you want to stop that blood? Because couldn't it go back into the brain?
Yeah, that's a great point. So again, you want to try your best to stop it, but you never want to apply pressure on the wound.
Okay.
So, what I would do is, we're going to talk about a little bit, is like laying them down, putting them in a position of comfort, treating them for shock. And so if you lay someone down with a skull fracture, kind of depending on where it is, that would probably promote the blood to kind of instead come, in some senses it's bad, but right, you want to come out of the body and into the dressing there, then staying in the brain. But again, that's nothing that you guys really need to worry about. Just think about applying pressure to the edges and trying to stop the bleeding, at least that you can see.
Okay. Got it.
Yeah, bro.
This might be a dumb question, but being cut, say, even though you're not supposed to apply pressure, if you did, could in theory your skull like cut your brain?
Yeah, exactly. So that's, again, that kind of came back to this example. If it cuts and then you're applying pressure, I don't know if it would necessarily cut it. It depends how jagged that edge is, of course. But just applying pressure could kill tons of brain cells, and we don't want that, and it can, again, cause permanent damage, paralyzation, and stuff like that. Okay, cool. Move on. Yeah.
Okay, so spinal injuries. There's some common causes of spinal injuries. Motor vehicle accidents, called MVAs here. Direct blows, so again, that comes from a lot of things. It could be just someone running into you, like football or something. Falls from heights, physical assaults, and then sports injuries.
And so recognizing a spinal injury. A lot of this, again, we'll probably touch on a little bit more, but for the most part, inability to move limbs. If someone says, oh my God, I can't move my left arm, that's usually an indication of a spinal injury. Again, your spine kind of connects your whole body, at least the nerves within your whole body. So that could mean that there's some damage. Numbness, tingling, weakness, burning sensation, and a burning sensation in arms and legs. Again, it's that same kind of thing saying, oh, if I can't feel my left arm, there could be some numbness there, things like that. Deformity of the neck, that one's usually very obvious if someone's neck is disaligned or something off there. And neck or back pain, this one is probably the rarest, at least in my experience on the ambulance. A lot of people complain of back pain, but at least when you hear someone has neck or back pain, you definitely want to be kind of aware that it could be something related to a spinal injury.
So sensation test, this is a big part of like what we do in a lot of our calls. Any injury, a lot of times we'll come back to this. So you're going to pinch the fingers and toes and ask, can you feel this? Just like as easy as just like, going on the fingers really quickly. Touch a certain finger and you can ask which finger am I touching and make sure they get the correct response for that. That's also a lot easier on fingers. Toes, like that can be hard. So just like I recommend doing that with fingers. And then you can go through your fingers and toes, make sure that they can do that properly on all limbs. And then ask the person to squeeze your hand or push down with their foot. So just like 2 hands, squeeze my hand, or you can put your hand on the bottom of their foot and see if they can like put pressure on your hand. And this is all stuff to just make sure that everything in their spinal cord is working and functioning correctly. Monica, did you have a question? Okay. Yeah.
And so care for spinal injuries, stabilize the head and neck, which I'm 95% sure we talked about in the next slide. Checking responsiveness, checking breathing, and providing additional care if needed. We've been over responsiveness breathing a ton of times. Okay, this is a good one. Again, kind of ties back to the first day. If the person is vomiting, you want to move them onto the side into recovery position. So instead of choking on their own vomit, instead they're vomiting kind of, again, outside of their body. Again, if anyone has any questions on that, you can ask, but we went over that first time. Then, of course, call 911 for additional assistance. Why don't we do, okay. So one thing that we're going to do quickly, just going to stray from the slideshow a little bit, is what we call C-spine. So this is what when it says stabilize the head and neck, how are you going to do it? So we showed you those one time with the C collars, right? That was here, yeah. So that's one thing that you can do to apply to stabilize the head and neck. The other thing is what we call C-spine here. So the way that it works is you basically take your 2 hands like this, and the way I was taught always, it was like kind of covering covering their ear, so their ear's probably like right around here. Then you kind of spread your fingers out a little bit, and you just hold their head on the sides the best as possible to kind of avoid their what? Oh, wow. Okay, so if Sally were laying down, it's going to be kind of awkward. You're like, lean back. It's going to be kind of awkward, so we kind of go like this here to stabilize her head and neck, kind of covering her ears. And then you just kind of, you don't put a lot of pressure, it's just a slight pressure. Not too much again. Too much pressure is not usually a good thing, so just a slight pressure in that position. Yeah.
So you normally do this for laying down, right?
Yeah, theoretically they'd be laying down. If for some reason they could be sitting in a chair or something like
I
that,
think they're sitting in their car.
sitting in their car. The most times I've experienced it just in the field is if someone's laying down.
Okay.
That I've actually used C-spine. Otherwise we'll use a C-collar, which we shouldn't do last time. Yeah.
And so for that, would you just like wait to get a C-collar to move the person, or do you have to?
So if you recognize that it could be a head or spinal injury and you're like, oh, I should probably stabilize the head or neck, just like here. Once you kind of do your assessment, or once you immediately recognize that that could be the issue, you would just hold C-spine, right, which we just demonstrated, and then you're not going to theoretically have a C-collar with you as a first aider, but then once EMS arrives, once we arrive in the ambulance, we'll be able to put a C-collar on them. Yeah, Tristan.
So if say their head's like crooked and you recognize that it's a spinal injury, are you going to move their head back or are you just going to hold it?
You're good. No, you never want to move it. You're just going to hold it in the spot that you find it,
Okay.
and then wait for us to fix that.
Just out of curiosity, why is it called like
That's a great. What is the C stand for?
Cervical.
Oh, of course, cervical.
Yeah, so on the back of your neck here, so kind of like right from like the bottom of your hair a little bit down is your cervical spine. So your spine's made up of cervical, lumbar, thoracic, or like all the way down the list. You guys should find that in your first aid text because I'm describing the bones. But so those first few bones right up here on your neck are called like your cervical spine. So it's just stabilizing your cervical spine essentially. And those are definitely the most common fractures.
There you go.
That's why we keep it in.
Yeah, that's right. Keep it. Okay. Any other questions on that? Now chest and abdominal fractures.
Alright, so chest injuries, there's closed versus open, which I think we talked about in other topics, I'm sure they'll go over it again. Rib fractures, impaled objects, and then sucking chest wounds.
Alright, so we're going to start off with rib fractures. So how to recognize a rib fracture. Sharp pain, especially when the victim coughs or breathes or moves. Of course, every time you inhale, your ribs are moving, and every time you exhale, your ribs are moving. So that's a common time that you would find someone who's in pain in their rib region. Shallow breathing. You guys know what shallow breathing is, right? We'll have a guess what shallow breathing is. Yes, Anka.
like almost sometimes ventilating kind of like
Somewhat. Hyperventilating focuses a little bit more on the speed of their breathing, but kind of on the right point. Usually shallow breathing and hyperventilation will kind of go hand in hand. Yeah, Rob.
Is it kind of like a more murmured breathing or is that something different?
That is probably something different. To be honest, murmured breathing, I don't.
That's more like there's something in your, like some kind of respiratory.
Oh, sure. So yeah.
More your lungs.
Exactly.
Exactly. Yep. Sorry.
If you have like bronchitis or something.
Yeah.
Oh, yeah. Avery.
Like a small breathing, like not breathing like fully.
Yeah, that's exactly right. Yep. So you're not inhaling all the way. Instead, you're only inhaling, half of your capacity or 75%, right? So it's a little bit more shallow than you would normally expect.
You're not going to get much oxygen
And then of course, finally, if the victim is holding the injured area, if they're clutching their ribs here, then that usually is an indication that there could be an injury in that area.
Okay, flail chest. So this results when several ribs in the same area are broken in more than one place. So, you got, I keep using football because I don't know why. Football, someone runs into you, right? And like multiple ribs are broken, not just two right next to each other. Maybe your bottom rib is broken, maybe your top. And the main point is just multiple broken ribs.
So how are you going to be caring for these rib fractures, whether it's a flail chest or just one rib fracture. So you're going to help the victim find a comfortable position for breathing. Of course, we always want to focus on our ABCs, airway, breathing, circulation. So in this case, the rib fracture would impede the breathing. So any way that we can try to improve that is going to be our goal. So whether that's sitting down, laying down. It's usually not laying down. It's usually kind of in like a
Almost a position where it's like,
okay, you can't really see, but kind of like I always was thought in like this position is supposed to be the most comfortable for something like that. And you notice that guy's holding a pillow, which I think we'll talk about, which is a way to stabilize a rib fracture. And then finally, so stabilize the injured area, and then finally call 911 as well. And you're calling 911 there, of course, because kind of back to the skull fracture thing, you never know, maybe one of the ribs had broken and then now it's pressing up against the lungs. That's obviously not good, so they'll be able to get to the hospital and treat them there.
and a heavy blanket, like a big blanket or a big pillow won't suffice for first aid. So impaled object, so first, I mean, this seems pretty dumb, but recognize an impaled object, there will be an object stuck in the chest. And I don't think that's hard to recognize.
So then how are you going to care for those impaled objects, of course? Again, we've said this a couple times now, never remove the object. It could be holding or it could be stabilizing things. It could be preventing blood loss. So you never want to remove them. Stabilize the object in place with bulky dressings or cloth, and then call 911. Ben, do they go over the donut, or do we have to do that?
No, we don't do that.
Oh, okay.
Well, you guys gotta sneak peek last time.
You guys gotta
You know what
sneak
they
peek
are,
at the
but you don't
donuts.
have to do that.
Yeah, exactly. You'll be super first aiders. Oh, sorry, my bad.
Okay, so sucking chest wound. This results when a chest wound allows air to pass in and out of the chest, having even breathing. So basically, I mean, that's kind of fancy wording, but it usually is a, impalement or some kind of wound to the chest that's letting in and air out, so on the lung. And then, recognizing the sucking chest wound, so there's going to be blood bubbling out of the chest wound, so that shows that there's in and air going out, and sometimes there's the sound of air being sucked in and out. So it, could come from like gunshot wounds or something like that, where it's on the lung cavity, so there's air coming in and out, so blood can be bubbling. Monica?
Does the person not breathe well if they have that? Or
Yeah.
would it be fine?
Yeah, they'll definitely have trouble breathing just because it could lead to a collapse run because there's air coming in and out, right? So most likely, one of the lungs is going to collapse, would definitely impede breathing. Tristan?
What is collapsed lung?
Yes, that just means that when there's not enough air, like your lungs are like bags, right, that keep blowing in and out air. So when one is punctured, it'll collapse. It can't hold any air anymore. So then your body's working with one lung, which obviously is not, efficient breathing.
And do you want to apply any pressure or just put a dressing on it?
The next slide.
Great question.
Okay, perfect. So to that, care for a sucking chest wound. So you're going to seal the wound with plastic or aluminum foil. You're probably wondering why use plastic or aluminum foil. And part of that is if you have like the normal gauze dressings that we have here. First of all, there's probably going to be a lot of blood, so that's going to get soaked up very quickly. And as well, you need to make sure, because that they're kind of still almost using that lung that could be involved to breathe, a gauze dressing like that would impede the air from going in or out. So what you see here the next time is tape on 3 sides. And you're also probably thinking, why tape on 3 sides? So that one side is actually open for the air that is coming out to, go in and out. So that's kind of the reasoning behind the aluminum foil as well as the taping on 3 sides, so that the person can kind of continue to breathe at least out of that lung there. If they're having difficulty breathing, which most likely they would, you want to remove cover to let the air escape. Okay, yeah, so sure. If they find that with this position they're actually still having trouble breathing, then you could remove the cover, right? So that would be the plastic or aluminum foil. So then you can let the air escape, and then you can reapply it in that position. You want to lay the victim on their side, of course, and then call 911.
Why would you want the air to escape? Air is not escaping now, right?
Right, correct.
So why would you want to let the air escape?
Yeah, that's a good question. So at least when I was taught back in the day, not really back in the day, like 4 years,
2 years ago.
like 4 years ago.
4 years ago.
So when I was taught 4 years ago, basically it's because why do you want it? Because it can build up, right? So if it is building up, just kind of uses here, people will have difficulty breathing to begin with. So it's kind of just building like almost like a balloon in some sort of that's kind of a weird analogy.
Don't want it to pop.
Yeah, exactly. So that's why as well that you would remove the cover so that you can release that air even more so that it becomes easier for them to breathe.
Okay.
It's all related to their breathing and making sure that, again, they're comfortable and not gonna die from not breathing.
So using your balloon analogy, if it did fill up like a balloon on the side,
Yeah.
would you just want to still uncover to one side, or would there be another way to relieve some pressure?
Yeah, so when you start it or when you first apply it, it still would be, you're still being only taping on 3 sides. So if, even with the 3-side approach, if the balloon is filled, then you can remove the cover and let the air escape.
And then put it back on.
And then, then reapply it, put it back. Yeah.
Why do you lay them on their injured side?
What do you say, sorry?
Why do you lay them on their injured side?
That is, I don't know.
Just to let the blood leak out.
Yeah, so it's like, it's going, if you're laying on this side, all the blood's coming out instead of, if I was laying on this side, it would just be pooling up, it's not injuring any good, I guess.
Again, building up in that chest region as well.
Also, I got out the dressing, so like, we wouldn't use the gauze in it, but you can see like this plastic material, right, this rope, this is like an occlusive dressing, meaning it's not sticky, it's like clear, kind of, what's another word for occlusive? It's like the back of this. This is an example of like occlusive dressing. So that's something you'd like put on. Or again, if you have a plastic wrap or tin foil, if you're ever in that incident.
That one's a little bit tricky, but I think you guys all got it. That's cool. Yeah, that's a good one to review because there are a lot of steps to treating it and stuff like that.
Okay, abdominal injuries. So if closed abdominal injuries, this could just be from a direct blow. And then open abdominal injuries are more penetrating wounds, impaled objects, and protruding organs. We kind of talked about this with just like general wound care, but closed, nothing is breaking the skin of the bruise, it's like a closed injury, for instance. Or like you could break your ankle and still be closed. And then open, something like something's broken the skin. So whether that's just small laceration or penetrating injury, something like that.
So then closed abdominal injuries, how would you recognize a closed abdominal injury? Bruising, as Sally mentioned, pain, tenderness, rigidity. You guys know what rigidity is? Use a good word of rigidity. Yeah. There you go. And then care for an abdominal injury. So how are you going to do it? Place them in a comfortable position again so that hopefully they'll be able to breathe as easily as possible. Here we go. Which is going to be usually on their back with their knees bent, so kind of what I was describing. Care for shock. So care for shock, which we'll touch on a lot. We'll talk about it now because might as well. That's going to be basically you're going to want to lay the person down and you're going to cover them with a blanket so they stay warm. Why do you think you want to cover them with a blanket? Or so they stay warm? Yeah, right.
Because when they're losing blood, cold, it's not good.
Yeah, so you want to try to maintain, obviously you guys know our normal body, let's see if we can get this. What is our normal body?
98.2.
98.6.
No.
6.6.
98.6.
Yeah, like
Wow.
Jacob, ready to go.
I was confident.
Fun fact, there are actually a lot of studies saying that our normal body temperature is actually lower than that. But don't think about that. Think about 98.6 when it comes to first aid class and EMS in general. But exactly, yeah. So you want to try to maintain that temperature as much as possible by laying them down and then covering them with them to keep them warm. Yep.
If it's like if you're losing blood and then you give her shock, but they're just close, so why are they?
Yeah, so there could be an internal injury, which could also be causing disruptions within your body that you don't want to happen to begin with. But as well, I don't know if you guys have ever been involved in any traumatic injury at all. You go into, it's not probably serious shock, but you go into a little bit of shock where the injury might not hurt so much because you have so much adrenaline or things like that. So the recovery from that is why, as well, no matter what injury we have, or for the most part, we still have them treat for shock by laying them down and covering them with a blanket. When we do our practicals, you guys will see that the last, I think, no, the second to last step with everyone is you're gonna lay the patient down and cover them with a blanket to treat for shock. And we'll talk about it lots more. It's a little confusing, but we'll talk about it lots more once we get to those practicals.
But yes, I think the first part of the question, bleeding can be seen, or can be like not. Internal bleeding is often not seen, but
Yeah. Oh yeah, sorry.
no, it's hard to detect. No.
No. Oh.
That's fine. Oh, okay. Protruding organs. So, recognizing protruding organs, just internal organs escape from the wound and are now not internal anymore. Well, a lot of reasons. A really big, like, abdominal laceration or something. You know what I mean? Like, if you get a giant cut, again, I hope this never happens on one, but, like, really deep, your organs can protrude from your abdomen because there's nothing going in it anymore. Or, I feel like this would be some really bad car accidents, you know, when there's some sort of major abdominal trauma, or some sort of maybe even penetrating injury or something. Yeah, it's basically a really bad abdominal trauma.
So how are you going to care for this? So you're going to put the person in a position of comfort, which again, on their back with their knees bent. Okay, we talked about this a little bit, especially when it came to the eyes. Why would you want to cover it with a moist, sterile dressing or plastic wrap compared to a dry? Oh, Caroline.
So instead.
Yep. Perfect, great. And this is also kind of weird, but your organs obviously are within your body, so they are moist to begin with. So again, you want to try to keep it in similar to the environment that it's used to. But also, I mean, that's the main reason. My reason is kind of the secondary. Well done. So how are you? Yeah, and then you of course care for shock, which you just talked about, and call one.
Like, if your organs are like coming out of your body, are they still connected to your body, or can they like?
Oh well, for the most part, they're still connected. I mean, it has to be super, super, super severe. That's kind of it would be a very rare situation, but for the most part, they're connected, but they're just sticking out of your body a little bit. So they're still like functioning, maybe a little bit reduced, obviously, because they're not their normal habitat, normal environment. But that would be very serious and very severe if they were out of your body.
You never want to be like separated from.
Yeah, that's it.
What happens if they do food?
We won't even talk about that because that's
You're
not.
good.
You
Like,
want
turn on the lights and start just go.
Yeah.
No.
Okay.
yep, Dalton.
Like, I would like to knock that eye. What if it's like dangling off? Do you like protect it on my bottom?
Great question. So if it's dangling out, that's gonna be, you're just gonna want to, you're not gonna like replace it or anything.
Don't shove it back in.
Yeah, don't shove it back in. But what I would do is I would like. This also is kind of a very severe situation that you won't need to worry about. But just for general knowledge, what I would do is I would kind of rest it. That if it's like coming out of their stomach, right? I would kind of rest it back on their stomach. Don't like force it in or anything, and then cover it with the moist sterile dressing. Again, nothing that you need to worry about at all. That's just. Nor I hope you don't encounter that. That would not be fun. Yeah.
Have you guys ever encountered anything like this?
No, I haven't. I've had a lot of rib injuries. That happens a lot.
Really close.
Car accidents.
That part.
Would you treat it like an amputation? Like if it does come out?
Well, it won't necessarily. It depends what happens, but it won't necessarily bleed as much as an amputation. You'd never ever use like a tourniquet or anything like that. So for the most part, no, they're completely different things.
I mean, you could like put on like moist like foam. I don't know.
Yeah, you won't have to worry about this. So yeah, just don't worry. All right, burns.
Types of burns. So you have thermal, which is heat burns, chemical burns, and electrical burns.
So depth of burns. So this may be a little confusing. Well, maybe, but I always thought it was. But so the depth of burns are the degree. First degree or superficial. What does superficial mean? Yeah, perfect, cool. So it means kind of nothing. I mean, it's like sunburn is considered a superficial first degree burn, or severe sunburn. So, or like what's that? What do you call it? No, not sun. What do you call it? Sun poisoning. Yeah. So that's like also, again, could be first degree, maybe even second degree, depending how severe. Second degree, partial thickness, and third degree, full thickness. So if you like burn your hand quickly on like something that's still gonna be first degree, but third degree it was like if you're in like a house that's on fire and your body is like basically on fire, then that would be a third degree burn. That's very, very serious. And we almost never have burns. The only time we have burns in this town is if people like spill boiling water on them. But that also happens pretty rare. All right.
So, superficial or first degree burn, so redness, you'll see mild swelling sometimes, tenderness, and pain. Pretty self-explanatory.
Second degree, partial thickness, things you're going to be looking for. Blisters, swelling, weeping fluid, which is kind of that like yellow stuff you see there, and intense pain. Obviously, this is going to be pretty painful. This is actually the most painful burn. Reason for that is because full thickness burns actually burn your nerves, so you don't feel the burn. So these ones are, the person will be screaming because they will be so painful. And not necessarily screaming, I don't know why I said that. But they will be in severe pain. Yes. Avery.
Is it possible to get that from sunburn?
No, that would be,
I think I got the deal.
then you might have. So like I
Or
mentioned before, if you have
sunburn.
something like sun poisoning, like Fiona mentioned, then it could, I was always told sun poisoning is kind of the line between a first degree partial or a superficial burn and a second degree. So things like those blisters could kind of start hinting that, okay, now it's maybe a second degree burn. Yeah, Meg?
Is it easier to get like a second degree over a super burn in front of the body?
Great question, yeah. So you know, obviously throughout your body you have kind of like different thickness of skin. So that all kind of depends. If you have very thin skin in one area, then that could be a little bit easier to burn. If thicker skin or more rough skin could be a little bit harder to burn. For the most part, I wouldn't consider that really. That's again more kind of EMT knowledge. I would just consider that you can treat the whole body.
What did you say?
That was nothing.
Who said that? What did you say?
Kind of looks like a pizza.
That's so sad.
I mean,
For a minute.
Wait, just for a hot second, that's not.
Yeah.
Sorry, third degree burn, full thickness. So like Tom said before, the nerve endings are burned, so it's like it is less painful if you like solely have a third degree burn, but what we learned in the EMT class is it's very rare that you will only have third degree and no, surrounding second degree or first degree burns. So if you get burned really bad, like on the middle of your arm, you might have like second degree here, first degree by the end of it, if that makes any sense. So it's still gonna hurt. It must be. And then leathery and waxy skin is very common, and curly, gray, or even charred looking skin. So these are super, super sweet.
When, like, how do you got hurt? When it burns through your nerves, will your nerves have to, like, not come back, but will, like, not come back again, or are they just kind of, like, done?
Yeah, so nerves, most, again, this is not what you should have to worry about, but from what I understand, they do come back, but you definitely, like, after getting a third degree burn, like, there's a lot of recovery after that. So yeah, I think you have to work to get back to full recovery.
come back also with reduced sensitivity.
Yeah.
So they'll grow back, but just it won't be as as sensitive as these. Yeah.
Like on that picture, like the worst, like third degree burn, all that.
That looks like pretty much all third degree burns to me, but maybe that is more second degree, but.
So I would say that is like not necessarily, because if you think about like a sunburn can be really, really red, right? But that could really only be if it's like a second degree-ish burn, if it's really bad, right? But the thing that you want to look out for is, again, kind of those blistering, the weeping fluids, the leathery, waxy skin. If their skin is like gray, that's like horrible, obviously. You don't want to run into it. Yeah, no.
How long does it take for fire to burn through like all the layers?
Yeah, I'm not sure. I would,
Google.
if you're, I know there have been situations where people have been kind of stuck inside, and then stuck inside a house on fire or something on fire, and they've come out with third degree burns. So I think it's probably a prolonged period of time, meaning like, probably prolonged period of time, meaning like minutes, compared to like other burns which can just be like seconds, really.
Yeah, you like touch a stove.
Yes, will. Okay. Right. Also depends on like what part of the flame it touches to, because you know you have like the hottest part of one flame, and then that temperature. We'll try to get through in the next few minutes here so that we can hopefully give you a tour. I think this is me. So the extent of the burns. So the rule of the hand. Oh, this is a good one. So victim's hand equals 1% of the body surface area. Of the patient's hand equals 1% of their body surface area. So my hand here is equal to 1% of the surface area of my body. So you can use this when it comes down to telling EMS on scene what happened, telling 911. You're going to want to look for which parts of the body are burned, other injuries, medical conditions, elderly or very young, and then you can use the hand technique and kind of see, oh, I have like a burn on my left arm, and it's like 1, 2 hands long, with the patient's hand again, so that would mean maybe it's about 2% of my body is burned. So that's a way to deduce how much is burned there.
Care for first-degree burns. So again, this could be a really bad sunburn. So you just cool, burn until pain-free. Ice pack. Sometimes when I get a really bad sunburn, I take like a really cold washcloth to do that. And then apply moisturizer such as aloe. That always helps. And then just administer OTC pain reliever as needed. So this would just be like Advil, Motrin, any type of ibuprofen.
Then care for small second-degree burns. Cool the burn until it's pain-free. This is kind of also pretty self-explanatory here, but a little bit more. Apply antibiotic ointment. Cover the burn with dry, non-stick sterile dressing. We use a non-stick dressing so that, because burns are often very almost like tender, so if it sticks to it, right, then it could like rip off, and that's not going to be comfortable. Then you have to take off the dressing at some point. Administer an OTC pain over the counter, by the way, but OTC means pain reliever as needed, for example, ibuprofen, and seek further medical care.
Large second-degree and third-degree burns. So this would just be remove jewelry and clothing so they do not stick, and any business and stuff. Then cover the burn with dry, non-stick sterile dressings. Non-stick, by the way, we do carry special burn sheets in our ambulances and non-adherent dressings, so those are good. And then just care for shocks, super big one with burns. Care for shocks, super important, and all of that.
Care for shock, would you still want to make them warm, or would you make them cool?
So it's a good question. With second and third degree burns, it's more important, I would say, to treat for shock. Just because, especially third degree burns, they're actually burns make you very dehydrated. So you're going to go into shock a lot much quicker than you would if you were, completely hydrated. So I would say, definitely lie them down. If you can put a blanket on, do it. If you can get them warm, I would go for it, unless they're complaining. But also, if they're able to complain, they're probably in better shape than they were. Does that make sense?
Yeah. Chemical burns. You can kind of see what it looks like there. So this can result from a caustic or corrosive substance. Things that we deal with in the chemistry lab a lot. Once you guys, or if none of you guys taking chem this year, but next year. So things like acids, alkalis, and organic compounds, things that can burn you. You don't want to put water on it if it's powder, because that'll create a reaction between the powder and the water, which would make it worse. And chemicals continue to burn as long as they're in contact with the skin. So that if they're not powdery, then you want to remove them as quickly as possible by flushing it with water. And probably the next slide talks about that a little bit. But I think that's one of the main notes. Just if it's powdery, you never want to put water on it, so it'll cause a reaction. Yeah.
What would you use rather than water?
Perfect. Yeah. So let's see. Yeah. It is. Let's see. Yep. Okay. We'll just do this slide.
Good question. So you can just brush brush or flush the skin to remove chemicals. So if it's powder, that's as simple as taking your gloved hand, trying to get it off. I mean, gloved hand's a little risky. You can always take a piece of dressing or a blanket, something like that. Get all the chemical powder off. Then remove any contaminated clothing, because that can continue to burn someone if it has the chemical on it. And then just cover the bird with the dry dressing. Same amount of cleaning. So just wipe it off first, make sure it's completely off, and then you can flush it out.
Okay, then care for chemical burns. We just did that. Care for electrical burns. Oh, okay, this is a big one. Make sure the scene is safe. So an electrical burn could be the result of a down power line or some other system, so you definitely want to be careful about that. Unplug and disconnect and turn off the electricity. That you can just ask someone to do. If you know how to do that, you can of course do that as well. Check responsiveness and breathing, as we always say. Provide CPR if needed. The reason why they say that is electrical burns can also often cause like arrhythmias within the heart. A defibrillator provides like electricity to restart someone's heart. So unfortunately, if someone gets an electrical burn, it can do that, but the reverse effect and then knock off the heart so that they then go into cardiac arrest. So you can provide CPR if needed, care for shock, as we talked about a lot today, and then fall. All right, last slide. Oh, no, that is the last slide. Okay, perfect. Yes, okay.
Quick question. So electrical and chemical burns, are they their own category, or are they also being categorized into a separate group?
So that's a great question. I think they can be their own, right?
So they're a type of burn, I think.
Well, I'm just thinking because of the symptoms that we see here, for example, with the chemical burn, and there's not a picture of electrical burn, I don't think, but I'm thinking that they can be classified as well, because if I'm looking at this, right, you can see some redness. Looks like there are some fluids coming out from around here. Obviously a little bit of blood. So I think that they're interchangeable as well. You can use the types of burns to describe a chemical or electrical.
Like you can say, I think you have a second degree chemical burn, I think that's
Yeah.
like second.
Yes, ma'am.
Can you like check that out without
Yep. Yep.
If you were struck by lightning, would you be dead?
Not necessarily. Most people that, we haven't had one in a while, but most people that are struck by lightning, what?
Do you have lightning strikes here?
Yeah. I think that's a few. And people aren't usually, they usually don't die. And the reason for that is because lightning's trying to reach the ground, so if it hits someone, which for the most part is pretty rare, then it'll go straight to the ground. And ideally, you don't want it to kind of pass through your chest. So it's pretty rare that someone gets struck somehow on their leg and then it goes to the ground. That would be the ideal situation. But for the most part, they're not always dead. But obviously it can result in a very serious situation. It usually does, but they're not always dead. Yeah, Jake?
And if there are blisters on second-degree burns, even if it's too painful, would you treat it as a regular blister?
No, you would not. You don't want to do anything with the blister. You just kind of want to stick to this and use a non-stick dressing. Yeah.
So you wouldn't drain the...
No. Different blister then. It's still a blister, but don't mess with it.
So we have 3-4 minutes. 5 minutes. So if you guys want, the tour will probably take 7. So if you need to go home, if you need to head home, absolutely, you guys can leave. Those of you who have already done the tour. So it'll be very abbreviated. You'll kind of get to see, so yeah, like I said, this is crew change right now. You get to see the ambulances out. You get to see kind of everyone going back and forth. So we'll do it very abbreviated, but again, don't feel like you need to stay, you need to head home. Go for it. But other than that, we'll see you guys for the quiz next week. We'll split you guys down to half if you guys want to come on the tour.
Oh, girl.